And welcome to our live stream here at Deuk Spine Institute. It is June 29th, 2023. We're just getting started on a patient with 3 discs. We'll talk a little more in a few minutes, but let me just get focused on fixing or accessing the L5-S1. L5-S1 is the most difficult disc to access when you're doing endoscopic surgery. Shot. And the reason is anatomically it's just very difficult to get to. Shot. All right, let's get an AP view, see where we are. So the 5-1 will be our first challenge. Then we're going to move to 4-5 and then 3-4. Now it turns out that looks good. You can see the vascular stents in this patient. He's got iliac vessel stents. Great, that's perfect. So things are looking good from our standpoint. Shot. Let's see if I can be in the disc. Is he awake? All right, very good. Can you grab my phone on there and see who it is?
Hello, my friend.
Let's go ahead and do a little more numbing medicine.
Okay, all right. We're going to ask you some questions, okay? We're going to ask you some questions. He's waking up nicely.
Try to answer it or call him back. Andrea? Like Andrea something.
Foot push up? Yeah. We'll just get it later. All right. A little incision. Gave him some numbing. Now he has 3 discs that are causing his symptoms. And he has 2 types of symptoms, back pain and leg symptoms. Now the back pain is one thing, and it comes from the tears in the back of the disc as well as his facet joints. In his case, he has facet joint pain, but he's also got disc pain. So we have 2 sources to the pain. Shot. One is facet, one is disc. Shot. Man, his facets are wide. He's got really wide facet. Shot. Meaning the facets are really lateral to the side. Let me have the knife. So I'm going to extend my incision just a little bit. And we've taken the epinephrine out of the injection, right?
Correct.
Yeah, but I gave him some numbing medicine. You're doing great. Lay still. You're doing fine. He's not moving around, but I just wanted to let him know everything's okay. Shot. Now, he's from Louisiana, right?
Yes.
Yeah. All right, so I'm trying to get into this L4-5 foramen, and you can see how collapsed it is. He's got a degenerated disc, and more than that, he actually has enlarged facets, which are the bones right where my needle is. Shot. Beautiful. If I can just get around. Shot. You doing all right?
You okay, my friend?
Where do you feel that?
You gave thumbs up. Where are you feeling that? You feeling any pain?
All right, don't move.
Where are you feeling it? In this back.
In your back. All right, AP. Beautiful. So you can see the needle on the x-ray is right at the back of the disc. If we're lucky, we'll be in the right spot. Oh, it's perfect. All right, let's find out from our audience if they have any questions so far.
No current questions.
Great. All right, very good. So at this point, we're going to keep going. Everything is going well for this gentleman. You're doing great. All right, that's 4-5.
Feel that in your back?
Yeah, we know you're going to feel it.
Yep.
We expect you to. And then we're going to place our last needle. And that's going to go at 3-4. Monica, show the audience the difference between L3-4 and L4-5 in terms of the disc height, you can see the L3-4 is much taller, more normal disc, whereas the L4-5 is more collapsed. So we would say the L4-5 is a degenerated disc. Shot. Okay, a little bit too low. Gonna head up north a little bit. Shot. Here we go. And as I'm doing this, I'm feeling around the facet joint. Shot. Any pain? AP. Where is it?
Lower back.
Perfect. Everything's going very smooth right now. So he's a bilateral 3-4, bilateral 4-5, and a left 5-1. Everyone agree? All right, you can see the tip of the needle is perfect. It's exactly at the interpedicular line between 3 and 4, at the back of the disc, right through the foramen, and it's low in the foramen. You want it low so you avoid the nerve root. You don't want to hurt the nerve root. You're doing great, my friend. All right, so that's, just relax, take a few deep breaths. We're almost done. We're going to put you to sleep soon, okay? If you're having pain, just tell me, num num, and I will give you some more numbing medicine. All right? You're doing great. Going to give him some numbing medicine right now, just to keep him comfortable. You know, what I'm numbing is the fascia and the muscle and the soft tissues, because those are pain-sensitive structures. Shot. Heading for that L4-5 disc. Shot. You can see right there on the X-ray. Shot. Where do you feel it? Back. Shot. Got to get around the facet, which I am. Shot. Give me an AP. Beautiful. Let's give him some more skin numb. You're doing great. I appreciate your patience. That's perfect. Very nice. We can see your stents, by the way. They look like two caterpillars getting ready to mate. Huh? Well, they look good, but we can't see the lumen. We can only see the outside. Now, we used to use epinephrine to minimize the skin bleeding, because that's all it's bleeding is the skin. And then we realized it was affecting the heart rate. And so and blood pressure, which we don't want the blood pressure going up, so we stopped using it. And ever since then, we've been doing, shot, been doing pretty good, right? There we go. Yeah, you felt that, huh? That was one of your bad discs that we're going to fix. We got one more to go, and we're going to put you to sleep in a minute. Luis, you want to get that? That's the downside of not using epi.
Let me clean that for you while you're at it.
Finally, yeah. Shot. Thank you, Luis. Just hold pressure there. Shot. All right. Where do you feel it?
Lower right back.
Shot. Shot. Let's get an AP. Little pressure there, please. Just put pressure down on the skin. There you go. It'll clot. Just takes a little bit of pressure. Let me know when you're going to take the picture. Count to shot. Perfect. You can see the tip of that needle is right there at the back of the disc at L3-4. You guys see that? Show them the needle at L3-4. We're about to enter the disc. All right, any questions, Henry?
No current questions.
All right. So we're going to place this, and we'll be done, and we'll be able to do our discogram. Okay, let's get a new one. Put it around. Put some pressure, please. Yep. All right, let me have it. So, let's see. Shot. Okay. And you can see we've got 2 needles at 3-4, 2 needles at 4-5, and 1 needle at 5-1. We're ready. We're ready. So let me talk to the audience. You can listen in, okay? So how long have you had your back pain for? 2006. Is that what he said? 6?
1996?
1996.
Yes.
All right. Can you hold this here?
Yes, sir.
So 1996. He's had back pain since 1996. We're going to write that. 1996. Lower back pain. Okay. So that's like what? How many years is that? That's almost 30 years. Like 27 years, right? So for 27 years he's had back pain. His life has been affected by back pain. Can you imagine that pain that you've had for 27 years is going to go away today for the rest of your life? How special is that? Okay? So his back pain, when I asked him, where do you get your back pain? This is what he showed me. This area right here. All right? And what do we have here? Well, we've got a disc called the L5-S1. We've got another disc, L4-5, and another disc called L3-4. So we got 3 discs, and he also had facet pain in the facet joints off to the side, on the left side, and they were tender. So I knew he had facet pain. I knew exactly which facets. I knew he had disc pain. I looked at the MRI. He had tears, annular tears. Are you comfortable?
Yes.
Yeah. Okay. No pain right now? Okay. All right. I just want to make sure you're comfortable. That's all. How bad is that on a scale of 1 to 10? How high? What high did it go?
What number?
What was the highest it went?
0 to 10 on the number. Pain score.
The highest it went.
Did you say 5?
I can't.
9.
9. All right. What number? That was L3-4. So at L3-4, he had a 9 out of 10. Is that where you get your back pain typically?
Pretty much so.
Yeah. So we have concordant pain 9 over 10 at L3-4. So what that means for those of you watching, never seen this before, we just tested the disc at L3-4 to see if it was painful. Indeed it is, and it's his typical pain he gets every day. Will you hold pressure there, please?
Yes, sir.
Okay. See how this side's not bleeding anymore? It's clotted. That side's still bleeding. So let's get it clotted. All right. So this is 9 out of 10 pain at L3-4. That's horrible. You could see when I injected it, I did not tell him I was injecting, so he had no way to know. But he tensed up and he said, ow. That's because he felt it. It's real pain. You hear that? Oh, how bad is that on a scale of 1 to 10?
10.
10. Is that where you get pain typically? Yeah, 10 over 10, L4-5. Concordant. L4-5, 10 over 10, concordant. You guys documenting? All right, is that better? So basically we've tested 2 out of the 3 discs, and they're both 9 out of 10 and 10 out of 10. And it's concordant, meaning that's the pain he gets every single day in his back. That's the pain we want to get rid of. That's why he came to Deuk Spine Institute. And we are going to get rid of it. There's no doubt in my mind. 100% convinced it's going to be gone. I've never seen a patient where it didn't work. All right, thanks for holding pressure. You better now? He said, yes, sir. Shot. How bad is that on a scale of 1 to 10?
8.
That's the highest, 8? Yes? All right. 8 out of 10. Is that where you get your back pain? Yeah. So we had 8 out of 10 at 5-1. So actually, of all 3 discs, the 4-5 was the worst. He had 10 out of 10 concordant at 4-5, 9 out of 10 concordant at 3-4, and 8 out of 10 concordant at 5-1. And every time I injected the dye, he tensed up without me telling him I was injecting. So it's a true test. The patient doesn't know you're doing it, and they respond because they're feeling pain, because the disc hurts. So we know the disc is the cause of the pain. Insurance companies don't want us doing discograms because they don't want us doing surgery. They realize that if somebody has a positive discogram, that means they're going to need surgery. And they don't want to pay for surgery. So they're trying to badmouth discograms so that people don't get them. All right, Monica, go to your x-ray and show us the tears at 3-4 in the back of the disc. That's not 3-4. That's it, right there. You see the black stuff there? Not that. Circle it. No, that's the nerve root. Yeah, no, right there. Yes, that's the tear right there, right where the arrow is. Show us the tear at 4-5. Right. No, it's the black line at the back of the disc. No, that's not the tear. That's the tear, yes. And then 5-1. Monica's been spending too much time in the MRI scanner. Not enough time in the operating room. All right, Monica, that's great. Thank you. Okay, at this point, we've identified the 3 discs that are hurting. We've identified the tears that are causing the pain. And now we're going to go in and fix them with the laser. Henry, let's show our audience how does the Deuk laser disc repair actually fix back pain by fixing an annular tear.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Shot. Okay, welcome back. Now you understand what we're trying to do is clean the tear so we get rid of the inflammation. It's the inflammation that's causing the patient's back pain and leg pain. You're doing great. Yeah, he's not liking it. Shot? Yeah, no, it's okay. He doesn't like it. I'm just telling the audience. He doesn't like it because this is the painful disc. This is the disc that's hurting him. Yeah, yeah. This is the 8 out of 10, but it doesn't matter. We're going through the painful area. We were talking about his stents. You can actually see the stents there on the x-ray. All right, we are ready to start fixing these discs one at a time. We have 5 discs to fix, and at the end we're going to do something called the Deuk plasma rhizotomy, where I'm going to go in and basically treat this facet joint pain with a permanent fix. And it's only available at Deuk Spine Institute. And here we go. Down the rabbit hole. I don't need that. I almost never use that anymore, you know? Let me get the laser. We're inside the L5-S1 disc. We're using the laser now, bringing it in. You're going to see it in a moment. There it is. Thank you, Oscar. So the laser fiber, for those of you who don't know, is 1 millimeter across diameter. Therefore, you can imagine the scale or how big this is. The tube itself is a 7 millimeter outer diameter tube. The inner diameter is about 5.5 millimeters. Let's just say 5.5. You can actually see the laser blast marks on the steel. You guys see that? There at the base of the tube. It's a discoloration of the tube. It's supposed to be silver, but you can see where the laser has melted the steel. So people ask me about, can the laser actually cut bone spurs? Of course it can. Huh? It can melt steel, it can melt bone spurs. Bone spurs versus steel, steel always wins. So if steel is stronger than bone spurs, which it is, then the laser can melt steel, which you guys can see. Then of course it can beat up a bone spur pretty good. That's like a Zuckerberg versus Elon Musk fight. Who's going to win? We all know Elon Musk is going to win. My money's on Elon Musk. All right, so let's get right to it. Let's get the bet started. Let's go start with Monica. I've already told you my bet is on Elon Musk in a cage fight. Monica, who are you voting for? Who do you? Zuckerberg? Now, is that who you want to win, or is that who you know is going to win? And you feel it because your ovaries tell you? No ovaries, I love it. All right, so why are you saying that Zuckerberg is going to win that cage fight? All right, fair enough. So she feels that Zuckerberg is better trained at this point than Musk. But what about 6 months from now? What if Elon Musk just goes full rampage, moves to Brazil, like moves in with the Gracie family, and just goes hardcore daily jiu-jitsu? All right, fair enough. Okay, next, Oscar. You're going Elon Musk, all right? Why is that?
I follow him here and there, but since he was a kid and an adult, he did jiu-jitsu, martial arts when he was younger, so he has already history with it.
So you're saying Musk has a history of jiu-jitsu?
Yeah.
Like when he was younger. So he's got that, like part of his childhood, part of his DNA, genetics.
He's very familiar too, so it shouldn't be a problem.
Yeah, I agree. All right, so we got one Zuckerberg. We got two Musks and one Zuckerberg because I voted for Musk. All right. Luis?
I like Elon Musk.
Luis is saying Musk.
Yeah.
Why?
I just like him.
All right.
Yeah.
All right.
I don't know.
Luis likes his character, his intensity. That's going to prevail at the end of the day. So basically, Zuckerberg might get Musk in a chokehold, but Musk will just prevail anyway.
He has longer arms. So.
Yeah, he's got longer arms. All right. Let's go with who's next? Who we got back there? Girls? Say, who's talking? Is that Sarah? All right, you're going for Musk? And why? Is he because he's better looking? Ah, okay. Character. So you just feel that Musk has the character to win? All right. Yeah, Zuckerberg has that baby face, doesn't he? Like a little boy. You could beat Zuckerberg.
He seems like a crybaby.
Oh, shoot. We got crybaby. The words flying around the operating room. Hope we don't have any. Hope they don't take us off Facebook, Henry.
I think we'll be okay.
Huh? The other one what? Stomping his foot? Right. All right. Let's go with. I'm gonna get Henry's vote next. Who are you voting for, Henry?
Realistically, I want Elon to win, but realistically, it probably will be Zuckerberg because
Okay.
he's just more committed into jiu-jitsu right now compared to what Elon is doing now. He would have
Okay.
to pick up the pace, you know. If anything, he would probably have to pick up boxing, and
Yeah.
that takes a while to learn. So with just years of experience, at least in the more recent, I would go with Zuckerberg for the win.
All right. And you're sure that Musk doesn't have like some secret jiu-jitsu training?
That would be amazing if he does. If he had some Matrix
Or a chip already.
little chip in him, learns
Right.
kung fu in an instant, that would be ideal.
Musk. He's saying Zuckerberg's going to win because Zuckerberg's been training longer than Musk at martial arts.
True, but Elon Musk has the advantage.
Yeah.
And that
Yeah,
al-
Oscar's like looking at it like a true, you know,
you have to count like stamina,
a
endurance.
boxing,
Yeah.
avid boxing fan.
Yeah.
Looking at height, looking at arm reach. He's looking at his physical abilities, saying because of those advantages, he's going to take Zuckerberg. He's going to crack him over his knee, crack his spine over his knee. All right, Berndes. Huh? Toss up? Musk? All right. All right, so Berndes has got his money on Musk. I think the Muskites take it. The Muskites. Time will tell. Monica says time will tell. Time will tell. I said Musk. Yeah, I just think Musk has the character. I wouldn't want to fight Musk. I mean, despite the fact that he's taller than me and probably longer arm reach, I wouldn't want to fight that guy because I see how he is. You know, people like him, you set your mind to something, you're not going to beat them. He could have his arm hanging off his body by a string, and he would still be attacking you. He's just got that focus, that determination, right? You don't think that's ever going to happen, huh? Oscar says it's happening. I personally think that would be the biggest grossing fight ever of all time. All right. Hey, do any of our viewers have a vote on this, Henry?
We got a few. We also have a couple questions, but until that, the comments, Canes25 said, I have to go with Zuckerberg. When you back a weasel into a corner, it becomes dangerous.
That's awesome. I love that answer. When you back a weasel into the corner. That's hilarious. All right, I like it.
And then
I agree.
And then another comment from AJ Hark on YouTube says Musk has a move called the Walrus.
And the walrus. Oh man, our viewers are awesome.
I know, I love them.
All right, let's get to the questions then.
Yes.
Let's stop screwing around.
Okay.
By the way, this is a very scarred disc. I mean, I've been hitting this with a laser and it just doesn't want to break apart. It's just taken a lot of energy. So this is all massive scar tissue at 5-1, tremendous inflammation. You could see the chronic inflammation. Like he said, we asked him, how long have you had back pain? Well, it's coming from this disc. He said he's had it for like, what do we say, 30 years, 27 years, something like that. So that's a long time, folks, for inflammation to be going on in your body, in your disc, in a small confined area. Okay, let's take some questions.
This first one, we have two questions. First one comes from Trust on YouTube.
Hello, Trust.
They asked, how do new up and coming surgeons train? Do they do surgery on cadavers? You would be an excellent teacher for our future surgeons.
Yeah, great question. Yes, they do. So let's address how do surgeons learn new surgical techniques. I think that's probably the best way to phrase the question, because you can be a surgeon who was trained and for a long time ago and still learn something new. And how does that happen? It's very interesting that you asked that. So first of all, we do use cadavers. But more importantly, we need to look at the economics of the question. And what I mean by that is training a surgeon is a very, very expensive endeavor, okay? And why do I say that? I preface the discussion by saying that because who is going to pay for the surgeon to be trained? Surgeons don't want to pay. They don't. They will not pay. So who's paying for all that expensive new training on the new technology? The answer is the company that is making that new technique or technology trains the surgeons, okay? So if there's a new cage, for example, to fuse with, the company that makes that new cage or that new device is going to pay for the surgeons to learn. And the reason is, the way they see it is it's an investment, okay? If they pay right now for that surgeon to get the training on their device, then the surgeon will go back to his hospital or her hospital and they will order that device for their patients. So basically the training has to happen first and a company has to pay for it for the surgeon to be trained. Now they will pay for the surgeon to fly for a few days to a city. They will pay for first class flight. They will pay for first class meals. They will pay for a hotel in a Ritz-Carlton. They will pay for everything. They'll spend probably $20,000 on that surgeon's training or more. Maybe it could be several surgeons at one time, which they'll pay $50,000 to $100,000 depending on how many surgeons, how many days the training is, okay? So the training is funded by companies that manufacture medical devices that are being put into patients. And now you understand why the Deuk laser disc repair doesn't have a huge following, because we're not paying for people to do this. I'm not going to spend my money to train a surgeon to do this surgery. I don't derive any benefit from it. So who's going to pay for surgeons to learn a new technology? It's the company that owns the technology. And since there's no way to make money from this surgery other than to do the surgery, there's no implants, no metal, nothing. There's no incentive, for example, for me to pay for other surgeons to fly here and train, okay? So that's part of the problem, but you need to understand the economics of the situation. And that is that companies that will sell billions of dollars worth of implants will pay for spine surgeons to be trained because they want the surgeons using their implant, okay? Whereas for me, I don't get any benefit or money at all from anyone for them doing my surgery. So I'm not going to pay for them to come here and train. They have to pay for themselves to come here and train. And I'm not going to train somebody on this technique in one weekend. They're going to take a year to learn, a year. So they're going to have to leave their family. They're going to have to leave their home. They're going to have to leave their practice for a year. Think about that. I mean, they make $1 million a year in their practice. Why would you sacrifice $1 million a year to come to Deuk Spine Institute, get paid nothing to learn this surgery? Right? Do you understand the problem? So the whole spine industry is built around companies that are enticing the surgeons to come and learn how to do their product surgery, and then the surgeons are going to go out and have their hospital buy those products and make the company money. Well, I don't have any way to make money off of this procedure from anybody. So I don't have any interest personally in spending my money to teach other surgeons. Okay? That's just the reality. And the thing about it, training programs like residency programs, fellowships, is they're making money on the surgeons coming and working for them for a year or 10 years. You know, doing free labor for them, making them millions and millions of dollars in profit. So the system is broken from an educational standpoint because the people that are training surgeons are the same people that are selling the cages and screws and rods. And they're incentivized to sell more, so they want to train more surgeons to use their stuff. And that's just the way it is. So, and it goes beyond training, by the way. If there's a busy surgeon, spine surgeon, who does a lot of surgery, they will go beyond just training that surgeon. They will incentivize the surgeon to use their stuff by giving them royalties or hiring them as a consultant when they're really not doing any consulting work. But they'll hire them anyway so they can pay them money to use their products and implant their products. Meanwhile, the hospital and the government or the insurance company foot the bill. So I see a change in all this in the future, and I think it's inevitable. As insurance companies want to save money, they don't want to pay for expensive surgeries, they're going to be willing to eventually pay for this surgery, and they're going to be forced to pay for it, all of them, because we're going to take them to court if they don't. And then eventually they're going to understand the benefit of this surgery over invasive surgeries like fusions and artificial discs, and unnecessary surgeries like laminectomy and discectomy. So this surgery will eventually be what everybody in the world does. It may not even be in my lifetime, but it will eventually be what is done as the standard around the world for a disc pain. I have zero doubt of that. Next question.
Next question comes from Severin on YouTube. And they asked, how many incisions/holes need to be made to repair the disc for anterior access when both arms are painful? 2 or just 1?
Oh, if you're talking about the cervical spine, which you are, you only need 1. It's only the lumbar and thoracic spines where you have to go on both sides if you have bilateral. So for cervical, I can fix symptoms in both arms by a single incision. I always go on the opposite side of the worst arm symptom. So if it's your right arm that's the worst, I will go on your left side. It's just anatomically makes sense to kind of go across the disc that way. Yeah, go ahead. Almost done here. This is taking me a lot longer than I expected because this disc is so badly degenerated and scarred. This is all like really thick scar tissue. And you guys can see how the laser is barely able to get rid of it. It just gets rid of the stuff right where the tip is, and I don't get any real help from the pressure wave. It's created by, it's called a cavitational wave. It's created by the discharge of energy from the tip. Normally, the cavitational effect is quite significant and helps me clean things up faster, but there's no cavitation effect when everything is scarred in the annulus like this. All right, just about done. Another 30 seconds and we're going to move out of this disc. We're going to move up to the next one. Keep the questions coming. I'm happy to answer them for you.
We have a comment and a question. This comment comes from Trust, once more on YouTube. And they said, this may be a little off topic, but something to think about that most people avoid talking about is body donation and free cremation, organ and tissue donation. Funerals cost thousands. Spend your money now and live your life. Have the surgery and live.
Yes, I totally agree. I totally agree. Being debilitated, incapacitated from pain, unable to do anything, is people don't realize how expensive it is. It's robbing you not just of the quality of your life, but of the productivity of your life, right? You're losing productivity. You're losing the ability to earn a living, have a meaningful relationships, enjoy nature, enjoy the earth that God gave us. So yes, you're right. Well said, Trust. Okay, just about done. I want to grab any more loose bodies down there. I don't feel any. There's something there. This L5-S1 has always been the hardest to fix and the hardest to get to. So I've said that many times. It's not because it's collapsed. It's because of the anatomy of the spine and the way that the iliac crest blocks access to L5-S1. You have to come at an angle, you know, which we did. But even so, it's difficult to treat. Keep the questions coming if you'd like.
This next question comes from Samir on YouTube.
Hello, Samir.
And they ask, will there be a price change for 1 disc repair and 2 disc repairs?
Oh, yes. Yes, Samir, there is. Every disc that we fix is more money. And some discs are more expensive. So the cheapest is the lumbar, what we're doing right now. I'm done. This is the least expensive. The cervical, I think, is the most expensive. Thoracic is second most, but lumbar is the cheapest. Don't ask me prices, because I can't tell you the prices. I don't have them all committed to memory. And, but we do have standard charges. Obviously, a bilateral is more than a single side if we're going on both sides. I have a lot of people who contact me and say, how much is it to do L4-5? And the first thing I tell them is, you know, they say, how much is the surgery? I have L4-5. The first thing I say is, well, we need to do an MRI review. And the reason for that is simple. Just because you've been told by somebody you have an L4-5 doesn't mean you don't have an L5-S1 or an L3-4. And I don't do surgery just because people want me to do a surgery. I do surgery because I believe it's going to fix the person's problem. So we're not here to take orders. We're here to make people better. But to do that, I have to look at the MRI myself, and I have to make a determination about what's causing that person's symptoms. And I need to see the actual MRI images to do that. I need to see the patient. I need to do an exam. I need to see exactly where the pain is coming from to do that, okay? I cannot do that, cannot figure out where the pain is coming from without an examination and without the MRI images. So I think people are a little surprised when they find out they can't just call me and say, hey, can you do a L4-5 Deuk laser disc repair? What's that cost? All right, let's go. Okay. So next, we're going to go left 4-5. Any more questions? Shot?
No current
Any old
questions,
question?
but we do have a comment from Canes25 once more on YouTube
Yes.
saying, learning and training is free. It's all right here on YouTube. Deuk Spine channel. It's all there.
Oh, thank you. Thank you very much. Shot? Okay, you can see the dilator now at the back of the L4-5. And I'm going to enter that disc next. And we're going to fix the L4-5. Remember, see how collapsed this disc is? Remember, this was the most painful for this patient. So this was the 10 out, was this the 10 out of 10? Yeah, right? 10 out of 10? Okay. Tube. Yeah. Great questions and comments. We really do appreciate our followers. And I appreciate the fact that you're all, the ones who come all the time, are willing to share information with others who don't come all the time. That we have a community that we've now built of people sharing ideas, sharing information, sharing concerns. Because I can't do it all myself. It's not possible. So the help I get from all of you is wonderful. And in the end, it's really about helping everyone learn the truth so people can make what I like to call informed decisions. It's all, it's all that matters to me is that people know about their options, they're informed, they know what's best, and then they make a decision. And it's not my place to control their decision. That's their choice. It's my place to inform them. So I see it as my mission to make sure people are informed. I don't see it as my mission to make their choices for them. Oh yeah. The good news is we have treatments that work, that eliminate pain, and are very low risk for complications. These are all pieces of herniation. There's a good size right there. Just came out. It was about 2 by 2 centimeters. Remember, this disc was super collapsed, right? You guys all saw that on the x-ray and the MRI? You can see it on the MRI. All right, Henry, any more questions? Let's get the laser.
Yes, we have a question from Samir, once more on YouTube.
Yes, Samir.
They asked, Dr. Deuk, just curious, do you use blue dye to find the tear?
I heard just a part of that. Do you use blue what?
Do you use blue dye to find the tear?
Yes. Yes, Samir. The blue dye, we call it the Deuk Spine blue dye, but it is a dye that stains blue the herniations, the nucleus pulposus, if you know what that is. It's the jelly in the center of the disc. And it doesn't stain normal nucleus pulposus blue. It only stains degenerated nucleus pulposus. Now, degenerated nucleus pulposus is abnormal nucleus pulposus. And the reason why it stains it, we don't know exactly why it does, but that was an observation made by my predecessors. They're the ones who taught me to use the dye. And they use it to stain the herniation. But I found that it doesn't stain normal disc nucleus, it stains only the acidic, spelled ACIDIC, low pH. It binds and stains the degenerated nucleus pulposus. So it helps me see the annular tear. It helps me find the herniation fragments. It helps me distinguish between scar tissue and herniation. Okay, good. Well, this is so collapsed you can see the end plates left and right. And we're going to pull back a little bit to see more of the herniation right there. You see the blue herniation. I apologize that the view is cloudy. The cloudiness comes from some blood from the end plates that are inflamed. And I apologize, but I can't stop it. It's very minimal amount of bleeding. It's almost nothing, but it's definitely clouding the view. Yeah, no, it's nothing to do with you. It's inflammatory bleeding. Bleeding from inflamed surfaces. Kind of like if you pop a zit. Yeah, it's all inflamed and irritated, so it's going to bleed a little bit. So the more inflammation in the area, the more it bleeds. Inflammation is an amazing process. It's truly a very ancient way for your body to attack foreign invaders. Inflammatory system is very old and not very sophisticated. It's like sending an army, infantry, okay? Sending infantry to fight, okay? Infantry with swords and shields. Against more modern weapons, they're dead, right? So your body has developed a second system, which is your immune system, which is far more sophisticated evolutionarily and more recent development. And the immune system doesn't do this stuff. It doesn't attack its own, whereas the inflammatory system has no compunction about attacking you and destroying your own normal tissues. And that's what's happening here. Huh? So not like an autoimmune disorder. All right? But autoimmune is autoimmune. I mean, there are rare instances where the immune system does attack yourself, but it's not common. Whereas the inflammatory system, that's all it does. It just causes a lot of collateral damage everywhere as it's trying to get rid of bacteria or fungus or anything it sees as foreign. Now, in the old days, the foreign things were bacteria and funguses, right? But nowadays, with the disc, it's not. And, right, we have antibiotics. So we use antibiotics to kill bacteria, fungus, virus, and protozoan pathogens. So we as humans don't really fight infections so much anymore. So now that the infectious agents aren't really a threat with all the modern antibiotics and stuff we have and treatments, the inflammatory system is not as important as it used to be, hundreds of years ago before we had antibiotics. So now the inflammatory system still attacks things that it thinks are foreign, and in this case it attacks your herniation, thinking it's foreign, when it's really not. But the other thing is the inflammatory system is necessary for healing. So it's the first step in healing. It cleans out the dead tissue and removes it, breaks it down, removes it. It's kind of like after the war with Russia and Ukraine, the destroyed cities will need to be bulldozed and they'll need to be, the debris removed, recycled, removed, whatever it is they're going to do. But all that destroyed buildings and concrete and steel, it needs to be broken down into little pieces and taken away. And that's what your inflammatory system does during normal healing. So as your disc gets injured and your body tries to heal it with inflammation, except that the problem is there's no end to the amount of material that has to be removed. So that herniation is too big, basically. So your body is trying to remove the herniation for years. And as it's doing that, it's attacking it and causing more and more damage to your disc. That's how you get degenerative disc disease. Now, we literally are the ones who discovered that here at Duke Spine. So you're not going to go read textbooks yet and find that. If you read textbooks, people will tell you, we don't know what causes degenerative disc disease. That's right, they don't. But we do. There's always a first. Somebody who discovers things first. And that's what we've done. All right, we're just working on L4-5.
We have a question.
Sure.
This comes from Severin, once more on YouTube.
Yes, Severin.
They asked, does Elon risk having adjacent segment disease the most as a result of the cage fight? Or are there other more serious problems that are more likely to happen to his spine during the fight?
Does Elon Musk? Yes, Elon Musk definitely has a risk of adjacent segment disease during a cage fight. And to me, as long as his fusion is solid, which I have no idea if it is or isn't, but let's assume his fusion is solid, then there's no risk at the site of the fusion of, you know, that coming apart. But if his fusion is not solid, then he could break his spine at that weak spot, and it could become paralyzed. So he needs to see his spine surgeon and make sure that he's solidly fused. You know, me personally, if I was Elon, I wouldn't do the fight. I wouldn't want to hurt my neck because he's had a fusion and he doesn't know about me. Now, if he knew about me, then it might be okay because he can get it fixed properly. But without knowing about Deuk's spine, he's going to go have some stupid fusion done again. And he's going to be miserable. So I don't think it's worth it, personally. And I think it's up to him ultimately to make that decision. But again, it needs to be an informed decision that he makes, the patient makes, you know. Huh? How much would they get for the fight? I have no idea. Yeah. Are they doing it for charity? I don't think so.
They are, actually, yes. That's what they said. They would not get a cent. All would be donated to charity.
So he's saying that they would donate to charity.
Yeah.
They're going to make a lot of money on social media, okay? And that's not going to go to charity. Maybe their prize money will go to charity. But they're going to both do very well on the social media side. I don't know how that's all going to work. I'm not in that business, so I don't understand it. But I would just be very careful if I were Elon with my neck. If it's not a quick fight, a quick, submission, we call it. If you can't get Zuckerberg quickly to submit, then I would, consider, before I get hurt, not fighting anymore. So, anyway, that's just my take. What other questions do we have?
No current questions.
Okay, good. Again, sorry about the cloudiness, but we do have a little bit of bleeding because of the amount of inflammation. It's tremendous amount of scar tissue here, just oodles and oodles and oodles of scar tissue. And I'm trying to just get it all cleaned up. Let's see. You can see the little bit of bleeding from the epidural veins. We call that Batson's plexus. And I'm at the back corner of the disc, so I'm almost done. And I just want to make sure I get as much out of here as I can so this heals properly for him. Remember, the goal here is to get the disc to heal. If we can get this disc to heal, there won't be any more back pain. There won't be any more leg pain. The disc will just heal painless. And that's typically what we're able to do. So since this is a long surgery, let's go ahead and show our video on how do discs cause so much back pain with inflammation. Let's show that video again. Wrap this disc up.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back, and you can see why disc herniations cause pain. It's a tear that's located in the back of the disc. It's called a posterior annular tear, and that tear gets inflamed because the nuclear material, or nucleus pulposus, gets stuck in it, and then that causes horrible inflammation as the body tries to remove that piece of nucleus pulposus stuck in the tear. And that inflammation goes on and on for years, like this patient for 30 years, causing back pain and leg pain. And that's what we're here to fix. We're going to clean that tear with the laser, clean the annulus, clean it all up, and get rid of his pain. So we're almost done, guide wire, with the left side. We've got one more disc to do at L3-4, and then we're going to move to the right side, do 2 quick discs, and then we got a Deuk plasma rhizotomy to do. So far we've lost about 10 cc's of blood shot. Can we give some num num? What do we look like? A num num factory? I can't, we're right on the disc at this point. Shot? So I would be numbing up the nerves, and I don't want to numb the nerves. What happens if you numb the nerves? Well, yeah, you get a nerve, numb nerve, which can be numb. Oh yeah, we're right on it. So let's get the guide wire out. In like Flynn. Oh yeah, yeah, we're already in. Thank you, Louise. Great questions from the audience. Good to have our old crew back.
My son lost a classmate. He was in a fraternity. He was raising money for a charity, and he passed away.
In a boxing match? He died from a boxing match. Out, out.
He was doing they were amateur boxers.
Here. Stupid. You see it on YouTube, these people fighting each other. You know? It's horrible. It's a shame. I hate to see violence. I really do. You know, I think sparring with martial arts is different because the fighters are supposed to be professional, and you know, they engage each other in a way that they're not trying to kill each other. But a lot of these YouTubers that are broadcasting fights, they're not professionals. They haven't been trained. No, it's stupid. A fraternity did it. No, that fraternity is going to be in a lot of trouble. I mean, just the lack of judgment, honestly. It's all about views. It's all about money. It's all about greed. That's it, huh? The attention, it's all about making money off the attention. That's what I'm saying. You know? It's a huge tragedy.
We have a question.
Uh-huh.
This comes from Running Myself Raw on YouTube.
Yes.
They asked, what if your pain is being caused by stenosis due to thickened ligaments and bony growths? Is the laser able to help with that?
That's a great question. Running Myself Raw, thank you. So first of all, there's a big misconception out there that stenosis causes pain. Stenosis never causes pain, never. Stenosis will cause nerve compression. Nerve compression will cause weakness, numbness, and tingling in your legs or arms, wherever your stenosis is. Doctors don't understand that. Patients don't understand that. Therapists don't understand that. And again, the whole system is just wrong about it. Stenosis is narrowing. It's a Latin term, Greek Latin term. It means narrowing. And we have different kinds of stenosis in the body. You have coronary artery stenosis when your heart arteries get narrow. You have carotid artery stenosis when the arteries feeding your brain blood get narrow in your neck. You get strokes from that. You get heart attacks from the heart arteries being narrow. And then you have spinal stenosis, right? And there's other kinds of stenosis, by the way, that you probably haven't heard about, like ureteral stenosis or urethral stenosis or fallopian tube stenosis. So stenosis just means narrowing, nothing fancy. So the question is, what happens when you get narrowing in your spine? And the answer is nerves get pinched, okay? So stenosis can be caused by bones, it can be caused by ligaments, it can be caused by herniated disc, it can be caused by a medical device being put in, like a screw, rod, an electrode. If it's not put in the right place, it will cause stenosis. The symptoms of stenosis are neurogenic claudication, which is numbness, tingling, weakness in the legs. That gets, usually better or worse with different positions, okay? And stenosis never causes back pain, and that's something a lot of people don't understand. Is this the scope, you think? I would look at it. May have to have this one maintained. It's hard to tell. Could be just material in the water column. But to me, it almost looks like the lens is vibrating with a laser, right? That could be the case. So your back pain is not coming from stenosis. It's not coming from thickened ligaments, okay? Those are all things the doctor will show you to try to convince you to do whatever treatment they want you to do. But you can't believe them. They're not telling you the truth. And maybe they don't know the truth, and it's possible. A lot of doctors don't. They think they know what they're talking about, but they don't. So your pain is actually coming from your discs, like this right here, a torn disc, or it's coming from your facet joints. And I can tell you exactly where it's coming from if I could see you, and I could look at your MRI, which I'm not going to just do. You're going to have to submit it for an MRI review. So that's how you get my free opinion. But aside from me, a very experienced spine surgeon who's cured thousands of people out of pain, because I know exactly where it comes from, without me looking at your films and looking at your back, I will not be able to tell you where your pain is coming from. I have no clue. I just know that it's the disc and it's the facet. The ligaments that get thick, I see them all the time in patients, thousands of patients, but they don't cause pain. I've never treated a thickened ligament and taken people's pain away, because that's not going to take your pain away. Now, typically, the kind of doctor that would be trying to sell you on this is one who's trying to sell you on a procedure called the mild procedure, M-I-L-D. Okay? So when you listen to people talk about their pain and their problem, if they're talking about, oh, I got pain in my neck, and I was told that I have Atlanto C1, C2 instability, and my C1, C2 are out of alignment, that's a chiropractor trying to sell them on treatments for like 6 weeks of treatment called VaxD, okay? If you hear somebody say, I've got a herniated disc causing my pain, it's usually a chiropractor trying to sell them on VaxD. If you hear people saying, I've got thickened ligaments and bone spurs, that's usually a doctor trying to sell them on a mild procedure, usually a pain management doctor, okay? Trying to make money off them, but it won't work. You can do it, it won't work. Then if you hear somebody saying, oh, I have an annular tear, and that's causing my symptoms because the disc is leaking out. That's usually a patient whose doctor's trying to sell them on disc seal or a barricade device. If you hear somebody saying my spine is collapsed and my spinous processes are touching, that's someone who's talked to a doctor trying to sell them on an interspinous device, like Intercept. Those things don't work, man. Okay, they don't work. Simple, they don't work. There's a lot of scams out there. I don't offer scams to my patients because I actually respect myself and my reputation too much to scam people. So I just offer people the treatments that really work, but the other people don't know how to do them. Because you actually have to be smart to figure this stuff out, and most doctors aren't capable. They're just capable of regurgitating whatever they've been told, and they're not capable of thinking for themselves. Unfortunately, it's just the way it is. It's what I've observed over the years. Okay? So, if you want to get fixed, you got to get the right treatment. And the thickened ligaments, these bone spurs, are not causing your pain at all. But thank you for sharing. And I always say, the proof is in the pudding. Don't believe me, believe the results.
We have another question.
Hold on, I got a question from the operating room.
No problem.
What was the question? What about bone spurs and other parts of the body? I think bone spurs and other parts of the body, like your shoulder, your knee, I think they could be the cause of pain. But I'm not a shoulder expert. I don't know. I'm the wrong person to ask about shoulders and knees. I don't pretend to know about things I don't know about. I know about the spine. And I know that when I operate on people and I leave the bone spurs there, their pain is still gone. It's gone because the bone spurs were not the cause of their pain. So, I don't tell people they need their bone spurs taken out if they don't. And 99% of the time they don't. Like right here, there's no bone spurs. But we're still going to cure the pain from this disc. Because we're not operating on bone spurs. We're operating on the tear. That's where the pain comes from. Yes, Henry?
This next question comes from Casa on YouTube. And they
Okay.
asked...
Hi, Casa.
Casa.
Welcome. Yes.
They asked, how long will the how long will the results last post-surgery?
Mhm.
And if so, how often does one need another surgery for returning pain?
Casa, thank you. Great question. This surgery you're watching is called the Deuk laser disc repair. It is the only surgery in the world designed to get rid of back pain and neck pain. The back and neck pain have to come from a herniated disc or annular tear or bulging disc, something to do with the disc, okay? And the results are permanent. There is no recurring pain. It doesn't come back, not with this surgery. Now, back pain has 30 different causes, all right? So there are 30 things that cause pain. We are literally fixing one right now, one. It's called the L3-4 disc. There's also an L4-5 disc and an L5-S1 disc and an L2-3 and an L1-2. So there are 5 discs in your lower back, and any one of them could cause back pain. But the ones that cause it the most are the L4-5 and then the L5-S1 and then the L3-4, in that order. This patient has 3 discs. So out of 30 causes of back pain, he's got 3. All right, but then he also has facet pain. And facet joints are these little joints in the back of the spine. We're going to treat his in a few minutes. And he has 3 facet joints as well as 3 discs that were causing his back pain. On top of that, didn't he have a piriformis or an SI?
Yeah.
He also had piriformis, which is a torn butt muscle called the piriformis muscle, and he has what's called piriformis syndrome. The treatment for that is a shot into the piriformis muscle. He had that done. Dr. Patel did it earlier today. So he has 3 facets, that's 3 discs, that's 6 total, plus the piriformis on the, left?
Yes.
Left piriformis and SI joint. So he's got, let's count that up. 3 facets, 3 discs, 1 piriformis, and 1 SI joint. That's 8 out of 30 causes for pain. So we have fixed all of them now, except for the facets. We fixed the 3 discs, and now we're going to go do the 3 facets. Dr. Patel did the SI and piriformis, and so, yeah. The key, though, is to know where pain is coming from, and that's 99% of doctors do not know where pain's coming from, and they say things like, oh, it's bone spurs or ligaments, and they try to convince patients to get surgery that really won't work. And they won't tell the patient it's going to work. They'll be honest about that part. They'll tell you, well, there's a chance it won't work. Yeah, there's like 100% chance it won't work. There's about a 100% chance eating rats won't work either for your back pain. But if somebody was going to make a lot of money selling you a rat to eat, they would tell you, well, you should eat this rat, but it's probably not going to work. I mean, why would you have a surgery that won't work? I wouldn't. If my doctor said to me, you know, we can do surgery, but I don't think it's going to work, I wouldn't do it. The problem is the doctors say, we can do surgery, that's your only chance of it working, and it's probably not going to work. Well, desperate people will do the surgery, right? Even though the doctor tells them it's got a 50-50 chance. At Deuk Spine, we're not telling you the surgery has a 50-50 chance of getting rid of pain. We're telling you it has a 100% chance. We just don't know if it's going to get rid of 100% of the pain. It's going to get rid of something. Our average is 95%. We've never had anybody with less than 80%, but the average is 95. So, all right, just about done. Another 10 seconds or more here. This has been a tough case. So this disc has been obviously massively damaged. All this is herniation and scar tissue. You can see how right there, you see how the tissue just gets vaporized very quickly? That wasn't what we saw earlier at the L5-S1. It was really scarred up, so it didn't vaporize quickly. It vaporized slowly. But this is more disc than scar, but it's still a substantial amount of scar. So it's vaporizing faster than 5-1 did, but it's still, just taking a lot of time and effort here. Now, I don't mind it. I'm happy to spend the time. But obviously, the longer the patient's under anesthesia, you know, there becomes a limit to what's safe. And so this patient in particular is really pushing the limit for us. You know, normally we won't do more than 5 discs, that's it. But we're doing 5 discs plus the facets. So for him, we are really pushing the limit of what we can do. That said, he is from far away, from Louisiana, and we don't want him to have to come back. So we felt bad. We said, all right, we'll do everything we can, and I think we're going to be okay. But just telling you, laser. Yeah. I'm just telling you that he's really, you know, when you watch our surgeries, doing five areas of disc plus the facets, that's just a lot. We don't like to do that much, okay? But we do it for people to save them the trouble of having to come back and get 2 surgeries, right? you know, there's risk of having surgery twice too, right? So a long surgery and 2 surgeries both carry additional risk than a short 1 surgery. So you got to kind of weigh things out for each patient and figure out what's best. For this patient in particular, we're using our CPAP machine technique. So he's getting good oxygenation, right, Doc? All right, quick peek. There's the nerve root in that fat over there. Let me get just a little more right here, Luis. I just want to get a little bit of this, make sure there's not any herniation there sitting underneath the nerve root. Sometimes you get a piece of herniation that just tucks up underneath the nerve root in the foramen, and that's not good either. So I want to make sure I get all that. All right. You see how a little bit of blood can obscure the view. Done. I'm happy with that. Think that will heal nicely. Scope off.
Do you want to do the DPR now?
Whatever you want to do. You want to do the DPR now, huh?
He's over there. That's what I'm saying. You want to stay there?
Sure. Yeah, fine. We'll do the DPR now. We're going to move to the DPR, Hen. Watch the needle, Luis.
Copy that.
So this will be mostly fluoro-based. You guys won't see that much, but you'll see the fluoro pictures. Okay? Yeah, you guys ready? So I'm going to take this tube out, and we were able to do all 3 discs on the left side using 1 tube and 1 incision. So I'm just going to put a little bit of pressure. Let's bring the fluoro in, stay in an AP, and bring it to the ceiling a little bit. Now, we've done the 3 disc repairs on the left. We're going to do 2 more on the right. And the reason we're doing the right side, he has right leg pain. When I looked at his MRI, I could see clearly that there was a problem at, hold on a second, that there was a problem with the right side of those discs. Okay, shot. All right. Yep. Let's, I need to see the spine a little bit better. And we're doing 3-4, 4-5, 5-1. Everyone agree? Shot. All right, Monica, I don't know what you're doing. I don't need to see the left side of his spine. I need to see my side. It's not terrible. Now let's see. We've got those needles at 3-4. You agree? Shot. All right, so I'm right on the transverse process at L3. Shot. And I'm now almost in a perfect position. Go ahead. Go ahead. Go ahead. To do the Deuk plasma rhizotomy at the L3 on the left side, which is what we want to do. So I've given a little bit of numbing medicine in order to reduce the amount of discomfort the patient has. Huh? Yep, numb. Shot. All right, not bad. We're close. Shot. So show us the target right there, actually. If you could see the tip, that is the target. Now this is the transverse process. That's what we're targeting. Let's see, shot. And we're targeting exactly where the tip is. You guys see the tip of that? Show them the tip. His muscles are jumping a bit, so it's making it a bit challenging. But, all right, that should be good. I'll move to the next one. Shot. Shot. You want to take him deeper? No, he's fine. No, he's fine. I don't need him deeper. If you want him deeper, by all means. But I'm okay. Shot? All right, that's the perfect spot for the next one. So we've done 3. This is number 4. We're treating his facet joints. For those of you who don't know, perfect. Literally perfect. Doesn't get better than that. It is the most perfect position right there. So that's 3, that's 4. Now we got to do 5 and 1. Let's come south, Monica. Wait, let's go pressure. Hold on, Monica, don't take a picture yet. I'm just applying a little pressure. I don't waste my time with that anymore. Are you guys ready? Yeah. No, I got 2 more to go. I got 5 and I got 1. Shot. You can see 5. Shot. You guys see 5?
Yes, we do.
It's actually a little lower than I am. And it's not far from S1. Yeah, it's close. Right there. Shot. That's it. It's perfect. Show us the transverse process, Monica. You got it. Well, down a little bit. It's that finger right there. Yes. You got it. Come out. Any questions about the Deuk plasma rhizotomy?
We do have a couple of questions. I wouldn't say necessarily relating to DPR, but this first question comes from Trust, once more on YouTube. And they asked, how much blood loss is there with open back surgery and why does that matter?
Trust, it's a great question. With open back surgery, and it depends on the kind of surgery patient's getting, there is a lot of blood loss. Shot? And blood loss matters because, well, you only have so much blood. And the fact is that you need it. You know, we all need blood. A lot of people don't realize blood is an organ that is an organ that basically is a liquid organ, and it's important. It circulates in our bodies, and 7 liters, is it that much? Really? I thought it was less than that. Is it really 7 liters? Shot? All right, I am not happy with that view. Let's fix the view. All right, well, we're getting the angle changed on the fluoro. I think you need to maybe go with this thing north, rotated. I just want to get a really good view of this transverse process. Not that, not that. I didn't ask for that. Huh? All right, whatever you got to do. See you can see the pedicle right there. I don't see the TP that well. Yeah, that's what I'm asking for, yeah. Just don't do too much. Do a little bit and get a shot. I'm not so sure that's better. Well, actually, it's not bad. You know what? It's not bad. I think I see the pedicle right there. Let's see. I'm a little below it. That's the problem. Shot. That's a little better. Yeah, I'm just not, that might be it. It's just hard to get to. I think it's abnormal. So getting back to Trust's question, blood is essential for us. And yeah, I'm not seeing the pedicle that well. Let's try to get a different angle. When you lose blood, it's bad, folks. And open spine surgery, surgeons will lose 500 or 1,000. That's better. cc's of blood. They'll lose 500 or even 1,000, sometimes 2,000 milliliters. So having a surgery like this that doesn't lose blood, well, that's great for the patient because your body needs blood to heal. So if you're losing it in the surgery, not only are you stressing the cardiovascular system terribly during surgery, during a very stressful time, but you're also hurting the patient's ability to heal after surgery because we all need blood to carry nutrients like vitamin C, oxygen, carbon dioxide, sugar, everything, fatty acids, all the things our body needs to heal. You need your blood for that. So by losing blood, whether you use 1,000 cc's or 2,000, you become unstable hemodynamically. Your heart starts racing. Your blood pressure drops. You become unstable. Yeah, you need blood for coagulation, for nutrients, oxygenation. There's so many reasons. So doing a surgery where you don't lose blood is wonderful for the patient because then they don't have to suffer the problems of not having enough blood. Shot? All right, it's too low. Show them where I'm aiming for. It's actually right there. It should be right there. Shot? Pretty close. All right, you guys see where my tip is right now? Shot? That's the perfect spot. It's just a little bit north of that, right there. All right, and that's the last burn we're going to do. Shot. We're going to do this last burn, and then we're done with the DPR. Beautiful. I'm all done. I'm going to come to the other side now while Luis comes over here, and I'm going to do the endoscopic disc repair on the other side. Like I said, this is a long surgery because we're doing so much. So much. We're doing maximum that we can do in one surgery. And I appreciate everybody's patience because I don't want to make the patient have to come back again. But, shot. Perfect. Okay. Here you go. Dilator. Num num, num num. Shot. Yeah, of course. It's better for everybody. Got to watch the tip of your guide wire shot. Make sure it doesn't advance. Remember, L4-5 is the really collapsed disc. Any questions, Henry?
Yes, we
Shot?
have two questions. This next one comes from Casa, once more on YouTube.
All right.
And Casa said, how is the disc sealed after repair to prevent further building / herniations?
Yeah. Great question. Great question. Is it Casso or Casso?
C-A-S-A, Casa.
Casa. That's casa.
Casa.
That's a house.
Ah.
Okay. So the disc will seal itself, casa. The body can heal the disc after surgery. So right now it cannot heal it. But when I go in there with the laser and I clean all that crud out, now it's clean and the body will heal. It just takes a year to fully heal. So the patient just has to be careful with lifting and with bending for 1 year. After 1 year, the disc is completely healed. And they can do whatever they want. Done. And they can go back to bending. They can go back to jiu-jitsu, sports. There's no restrictions. Yeah, it's perfect. There's no restrictions. So during the year, the annulus seals itself. It just can't seal itself right now. Hey, look at that. Go, start moving it back as you're doing that. You don't have to have everything locked. You can keep it fluid, and as you're rotating out, you're moving the base out. So it's not one step at a time. So here's what happens, all right? Here's the annulus. Can you see this, Henry?
Yes.
The annulus rips, and then you do something like bend over, and it pushes the nucleus, and now the annulus can never seal again because the nucleus herniation is in there. I go with a laser, I clean all that out, and that allows the disc to seal. It's the only surgery in the world that allows the disc to seal again. There's no other surgery. There's other gimmicks out there like disc seal or barricade. They don't work. I wouldn't recommend them. We have a lot of people who get those procedures done. They come back to us afterwards and say, it didn't work. I told you it wasn't going to work. You don't listen. So people do funny things, but I don't blame them because they trust their doctor. Their doctors have misled them. So it's not the people's fault, it's the doctor's fault for misleading them. There's no accountability. It's the problem. Because doctors lower the expectation of the patient before the procedure and say, oh, it's probably not going to work, but this is the only thing we can do. So, oh yeah, that's a pretty big herniation right there. See all that? That's stuff that's stuck in the annulus. Here it comes. Ah, it broke apart. I'd love to get it all coming out as one big herniation so you guys could see it. Oh yeah, come on now. Come on. Oh yes, we got it. It's coming. Oh, no, maybe not. Ah, it doesn't want to come. It's like trying to bring a tuna up from the deep. Is it snapper season right now? Yeah. Yes, what a pain. This patient is committed to making this a difficult surgery for me. Right, Luis? Just, it's coming up in fragments, so I'm not happy about it, but it is what it is. I can't change that. These are all pieces of what I believe to be a very big herniation. And I was hoping I could bring it out as a big fish, show you all.
Yeah, I'm gonna give you, yeah.
What is it?
He wants a specimen.
Oh, we got plenty of specimen.
Sarah, can I have more right there, please? Thank you.
We have another question.
Laser? Yes.
This comes from Severin on YouTube.
Yes, Severin?
They asked, what could be the long-term consequences of drilling through spine, probably facet joints, during posterior endoscopic surgeries? Damaging less than 50% of a facet joint does not result in instability?
Yeah, Severin, great question. First of all, I'm not sure what you're referring to by posterior endoscopic surgery, but that's a very good question. The surgery you're watching now, we don't drill through the facet joints. That's what happens during microdiscectomy. And true endoscopic surgery like mine that you're watching now, we don't drill through facets. Okay, that's done with other surgeries that are open surgeries. And by the way, removing any of your facet joint is going to destabilize the joint. They lie to you and tell you 50%. is a magic number, but there's nothing magic about 50%. Oh yeah. Damn it. Got stuck in the tube. No, it's stuck in the tube. Look at it. Ha. This is a massive herniation. And I've been working on it for the last 10 minutes, and it just doesn't want to come out as one piece. So, you know, the ones that come out as one piece are pretty scarred. Anyway, getting back to Severin's question, the posterior Deuk laser disc repair you're watching, we don't remove the facet joint at all. Because if you do, you're going to weaken the spine, destabilize it, patient's going to need a fusion done. All these other surgeons that you talk to, they're all going to take away part of your facet joint. They're going to weaken the spine. That's the beauty of this technique. This technique was developed by Dr. Parvis Camben. You go through the neuroforamen and you don't remove any facet joint. I cannot get that. It is so big, literally so big and so stuck down that I cannot pull it out. It's just little pieces. How's our last patient? I have no irrigation. Yeah, I need irrigation. All right. She can go. She can go. I'm going to be another 20 minutes. Maybe, finally, no. Just doesn't want to come. It's too big. Literally, this got to be the biggest herniation I've seen. I've been picking at it for 15 minutes now, and I'm taking pieces, big pieces off of it, and it's still too big to come out. I mean, it's unbelievable. Have you ever seen a herniation this big? I have never seen one this big. I am taking chunks and chunks and chunks.
Let's bring Grabzilla.
Oh, Grabzilla. Do it. Get Grabzilla. What the hell, why not? Fuck. Take it. We're going to get Grabzilla. This is a job for Grabzilla. For those of you who...
Ready on the laser, please.
For those of you who don't know who Grabzilla is or what
Press the
Grabzilla...
button, ready, and that's it. Ready. Yeah, ready. Thank you.
Thanks. Those of you who don't know Grabzilla, Grabzilla is our massive grabber. Big. It's like a giant excavator. Huh? All right, give me Grabzilla. Scope off. Let's show the audience. Turn the light on. Henry,
Yes, sir.
let me show you Grabzilla. Oh. Here. You guys see it?
Yes, we do.
Look at the difference here. Grabzilla versus endoscopic grabber. It's like Godzilla versus King Kong. Who wins? They always make it look like King Kong might win, but in the end, we know who wins. King of the monsters is not King Kong, it is Grabzilla. There's a big piece, but still not the prize. Oh, I feel pieces of it just breaking off. Part of Grabzilla, what it does is it cuts. Oh my God, that was another big piece. We've been taking huge pieces out. This is literally going to be one of the biggest herniations I've seen come out of a disc, but unfortunately it's in many, many pieces. It's not one piece. Let's go see what we've done. But basically, the herniation is three things. Number one, it's too big. Number two, it's too scarred down. And number three, it's too soft. It hasn't collagenized enough. It hasn't scarred enough. Does that make sense? In other words, it's too fresh. If we left it in a few more years, it would be more scarred up, and it would be more tough. It would come out together as one big piece. My God. Oh. Oh my God. Look at this, Henry. After all of that, it's still humongous. It's just too funny. Sorry. Oh my God, that thing is huge. All right, I have to say it. Smack its ass and give it an APGAR score. All right, so you can see this thing's a beast. But Grabzilla and little Grabzilla were too much for it. Can you see that? 3
Yes,
centimeters long.
Yes, we can.
Okay, that's after we like took away at least 60% of it, and that's what's left. All right. Anyway, you know, when you're in the operating room for so long, you gotta enjoy some of it, right? You know, you gotta get it entertained a little bit. Here, take this. Name of the grabber again. This is how we spine surgeons entertain ourselves, by laughing at how big the herniations are. Still more. Look at this. I mean, this is a big guy, but this is like the biggest herniation I've ever seen. Incredible, huh? I mean, this is... Someone call my wife. Tell her I'll be home for breakfast. You guys, this is the biggest I've ever seen. I mean, still more. I can't even get this piece out because it's so damn big. Yeah, but Grabzilla has a tendency of being a little bit too physical. I'm trying to finesse it out. There we go. Yeah. Still not all of it out. Yeah, I think I need Grabzilla again.
Lights on, please. Thank you. Scrub on.
Oh, it's all right. I don't need the lights.
Yeah, scrub on.
Nope. That's the problem. I think Grabzilla is going to shove it back in. You know what I mean? That's what I think's happening. Grabzilla is just pushing it back into the disc. So let's see what I can do here. If I can finesse it a little more. Maybe I need to pull back on the tube. Yeah. All right. This is why grabbers suck, because they just can't release the herniation from the tether on the annulus. People always say, why do you need a laser? Well, you need a laser because the disc herniation doesn't come out. You know, it's stuck to the annular fibers. So you gotta have something to release it from the annulus. Man, that is murky. All right, any questions?
No current questions, but we do have a comment from Truss, once more on YouTube, who said, a shout out for the ones behind the scenes, also the staff that answers your calls and answers questions. Very professional and pleasant.
Oh, that's Henry, it's you.
It's
You got a shout out, Henry.
I believe so. I mean, I appreciate that, Truss. Thank you.
Yeah, that was awesome. All right, well, at least we know why this patient had so much pain, right? And so much leg symptoms on both sides. We're just about done. Let's see here. Grabber. You guys see the blue color, right?
Yes, we do.
Yeah.
We have a question.
Sure.
This comes from Teresa Williams on Facebook.
Uh-huh.
They ask, does L3 disc problems cause knee pain?
It can. L3 disc problems can cause knee pain, yes. Because the L3 nerve root runs by the knee. So it can definitely cause knee pain. Grabzilla. Just about done with this one, and then we're gonna do nothing more to grab. Let's see, how's our irrigation? Good. Luis? Finally. All right, I think we're done here. This is like the never-ending herniation here.
Teresa asked another question.
Look at that. Do you see another giant piece? Yeah.
She asked, what about weakness in the knee? Can an L3 disc cause that?
Yes, L3 disc can cause Weakness in the knee. Absolutely. That is correct. Great question. Done.
Right on, please. Thank you.
Yep. The knee is innervated by the muscles are quadriceps and a bunch of other stabilizing muscles, L3, L4. So L3-4 herniation can definitely cause that weakness. You know, but you really need to have a good doctor look at your MRI and do an exam. And it should be pretty obvious if you have a herniated disc at L3-4 and is pinching the L3 or L4 nerve root. And it's very easy to fix with this surgery, the Deuk laser disc repair. That's what I would recommend. Any other surgery is going to be way too invasive. No, you're all right. Just leave it. Thank you. Other types of spine surgery, the surgeons are removing the bones and ligaments that you need in your spine. But with this surgery, we're going around the using natural holes that are already there. Start turning it already, you know. You don't have to just move in one direction. You understand? Monica?
I hear you, sir.
No, you hear me, but you got to do it. You can't just hear me. Okay? Let's go. Shot.
It's under there.
All right, so we've completed everything except for L3-4.
It's all right.
Shot. Looks like your X is back. Go ahead.
That one was my fault.
It's always your fault. It's not like the fluoro has a mind of its
I know where
own.
that one came from. How about that?
Well, you got to know where they all come from. Let me feel it. Come out.
Yeah.
Okay. Out. See?
Yes, but I don't have control.
Yes, you have control. All right. We are now in L3-4. Grabber. Left side. Sorry, right side. Getting my right and left mixed up. Very nice looking disc. Okay? See the difference here. It doesn't look all stuck together like scarred disc does. It's a lot fluffier. Have the grabber ready. So you look at the consistency of this disc compared to the last ones, particularly L4-5 and L5-S1. Look how much softer and fluffier it looks. This is a newer herniation. Now, it could still be years old, but it's newer compared to the degenerated disc we saw earlier. Hey, Luis, what do you think about the stain? You happy with the amount of stain?
That's what I realized the previous surgery. It's not that blue, right?
Right?
What do you think? Yeah, yeah.
So maybe it's less concentrated per mil?
It's supposed to be the same concentration, but I mentioned to Sarah, I say it looks.
Doesn't matter.
Yeah.
I mean, Sarah can't find anything else.
Yeah, no,
So you're going to have to adjust how much you put in, right?
oh, we can, yeah.
So how much do you put in?
Was Sarah's here?
So what's the final concentration versus the volume you're putting in? What's the final concentration of the solution?
I think it's 8%. Indigo.
No, I didn't ask you that. How much of the indigo do you draw up?
We draw 5 mLs, and we put it into 40 mLs of omni.
See, that's what I'm asking. 5 and 40, right? So maybe we need 10 in 40. And do we need 40 mils final volume?
Sorry?
I'm asking you, Luis.
So if you did 10 mLs of 40,
Yeah, that's what I'm asking you. But do you use 40 cc's? All right. Well, I'm just saying, I think
Well, it's normally also a little bit more diluted than that because
a little what?
it's also a little bit more diluted than that because we normally put it in 40 mLs of omni and then there's like 5 mLs of marketing in it as well.
All right, so what's your final volume? So you take 40 of Omni,
Right.
200, right?
200, yeah, 200 milligrams.
You take 5 of, yeah, indigo, and 5 of lidocaine, marcaine, whatever. So that's 50 mils, right? So I think we need to adjust the concentration. I mean, it's not bad.
take off 5 cc's on the omni-pig. So put 35 of the omni-pig. And then put 5.
Yeah, 35 omni-pig,
35 omni-pig.
10 indigo.
I would just say 10 of the indigo, yeah.
Yeah.
Just double the indigo and see if it's too blue.
For the next one. Let's try for the next one. Double the indigo.
Yeah, let's just try it. Since it's a new manufacturer, you know, could be they're not putting as much in there. Right? They say they are, but we know where it's made.
Rich blue as the.
It does. That's
Does,
really
yeah.
weird. I mean,
As the prior indigo.
Oh, it's not bad. It just seems light to me.
we thought it looked like equal, you know, the same.
Huh?
I saw the blue on the big disc. It seemed like it was there, but maybe not as bright.
I wonder if we could just take out more omni-pig because
Don't grab the tip. That doesn't help. You understand?
I understand.
There you go. Pinch it. Pinching it. What is it?
if we wasted more omni-pig, it would still increase the concentration, but omni-pig is less expensive than the indigo, you know what I mean? Instead of using more.
Yes, but that's why I asked overall, do we use the full amount, the 50 mils for the surgery? Or how much of the 50 mils?
Use the full amount for the surgery.
How much do we use?
Depending on the level, we use 5 mLs per level, so it would be like 15 for this one.
So 25. So you don't need the full 50 mils. So you should plan on making 25 mils. What vial is it in?
It comes in 5 mLs, 5 ml.
What does?
Well, that was for the ankle actually. I think the new ones have.
No, I'm asking about what is the vial that it's in right now, the 50 mils?
It's in the omni-pig, right?
It's in an Omnipic vial. So you just use a full Omnipic vial. Well, there's no way to take half of it. You just have to remove half of it, right?
Right. Yeah, we always look smarter.
So then maybe that's what we do, is we take the Omnipic vial, which is 40.
Omni-pig vial originally is 50, but we just prior to
Oh, you get rid of 10. Got it. So maybe you get rid of 20 next time. Then again, our dye, you know, I don't think we're hurting for the dye on the x-ray. That seems to be plenty. It's not diluted. It's good. 10 minutes or less. Actually, probably 5 minutes at this point. Man. So his herniations were a lot worse when I got in here with the endoscope than they looked like on the MRI. Seems like, yeah.
CPAP's maintaining a good end tidal CO2.
Good. What's your end tidal CO2?
40, between 40 and 43. It's normal.
Yeah.
Which is great for prone position for 3 hours of sedation. It's phenomenal.
That is great.
Normally it rides up past 50.
It worked. So what do patients experience different? Anything on their, do they feel more rested?
I just think that you can maintain a more equal level, more consistent level of anesthetic with it. Because it gives the anesthesiologist a little more confidence because you're seeing a steady CO2, you're seeing a steady breathing pattern, you're giving positive pressure in the airway, you're giving oxygen, so it's more of a good plane. You notice the plane is.
So you're saying physiologically they're stable, more stable throughout the surgery.
You notice the plane is pretty good when you're operating.
So the patient may not notice any different when they wake up.
And I noticed
Yeah, yeah, yeah.
the vital signs,
Yeah.
the depth of the anesthetic.
You're not chasing things as much.
No, you're not bolusing as much either.
That's good. All right. 1 minute should be roughly. I don't see any giant herniations here. So not like the last one. That was pretty impressive, huh? I mean, we dug at that for 20 minutes, 30 minutes. This is much softer. You can see how the herniation responds to the laser energy. It's very different. Any questions from our audience?
No current questions. We just have a comment from Teresa once more on Facebook saying knee pain and I have knee pain and weakness when driving and going downstairs. Also the pain goes all the way to the feet. My disc bulge is L2-3, L4 through 5. The MRI shows very little space between my L4 and 5, and my pain is elevated when sitting. And then Truss added to that comment, I didn't know lumbar causes knee pain.
Yeah. Lumbar disc herniations can cause knee pain if they are higher up at L3-4, L2-3, even L1-2 potentially. But L5-S1 herniations do not. It's because both the sciatic and femoral nerves come off of the lumbosacral plexus. Therefore, herniated disc in the lumbar spine most commonly affects the sciatic nerve running down the back of your leg, but it can also affect your femoral nerve, which runs in the front. And therefore, people, if you look at the anatomical charts from Netter, you'll see that L3, L4, L2 all run in the front of the thigh. Femoral nerve distribution. All right, just about done. Feel free to type up any questions. I am going to head over there in a few minutes, see my last patient before we come over there and type up your questions. We are just about done, 30 seconds. I've cleaned out this disc. This is the healthiest disc of the three, just looking at it internally. And you can see the epidural space right there. A little vein bleeding, no big deal. And I'm very happy with that. I think he's going to be happy. That's what matters. I'm happy if the patient's happy, so My happiness is predicated on the patient being out of pain, which I think he will be. That's the good news. All right, type up your questions, and I'm pretty much done. Thanks, everyone. We're going to put a little antiseptic in there. So did you try the super glue?
Yeah, I
Dermabond?
tried one of the patients.
Just doesn't work that well, does it?
Well, actually, for the cervical.
The cervical?
The vampire bite.
It worked? All right, but you know you can't put steri strips on top of that.
No.
But she had steri strips on her neck.
On the top.
Oh, posterior
Yeah,
cervical.
yeah.
I'm done. No, we don't need suction. Thank you. All right, let's show the audience the incisions. So I always like to hold pressure for a minute. There's some, by the way, there's some disc herniation there. We have plenty of it. All right, you break that down. So I would call blood loss 15 cc's. I don't feel any hematoma, but you guys can see the incision for the DLDR.
Yep.
It's about 8-9 millimeters, and then you can see these 3 millimeter incisions for the DPR, which is the facet treatment for facet pain. So we treat it as disc pain and as facet pain. And if you remember from earlier, he's had pain since 1996. Here's the incision on this side. This is a little smaller because we only had 2 discs to fix. This one's a little bigger because we had 3 discs to fix. All right, let's see what we got here. I don't feel any hematoma. You can actually palpate the muscle and you can feel there's no hematoma. There's just a little bit of venous oozing, no big deal, it's normal. And I'm gonna have Luis pop in a staple. We'll get it out tomorrow.
Yep.
You ready?
I'm ready.
Do your side. Blood pressure is perfect, Dr. Berndes says. All right, go ahead and cut to the testimonial and let's have people type up questions. I'll be there to answer them in a few minutes. Good job, everyone. Luis, thank you so much. Thank you, Oscar. Monica, thank you. Everyone, great job. Dr. Berndes. My nurses. Good morning, I'm Dr. Deuk at the Deuk Spine Institute here in Melbourne, Florida, with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Deuk laser disc repair. We performed that 12 hours ago, and here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics, killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here. And I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day, and I feel great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you, It took me a few months to get here, and it was worth the trip.
It will be for the rest of your life worth
absolutely.
the trip. Pain robs us of our dignity, doesn't it?
It does. It absolutely does.
And your parents are here, and they're very supportive. And that to me is so important, that you have people that understand what you're going through. I'm sure your parents have been a big support for you.
Oh, absolutely. Yeah, I was at work, a short story. I was at work last Wednesday dealing with this pain, and my back finally gave out to where I literally could not walk anymore. And I was 600 miles from home. And so I called my mother and father. They flew to San Diego and arranged the trip to get here. I called your place. I was scheduled for February 2nd, and I asked Richard on the phone if he could get me in sooner because I was desperate. And you guys got me in a week or two sooner, got me in the 24th, which was yesterday. And so we made the arrangements, and I flew here, stayed in the hotel for a couple days, and was operated on yesterday. And yeah, it's well worth the trip. I apologize for getting emotional, but it's been a long trip to get here.
Well, we want you to get emotional, because it is an emotional thing. When you've been burdened with this pain for so long, and then suddenly it's gone, and you realize that life can be lived without that pain, you know, and that you can actually have a life without the pain.
Yeah.
So what are you going to do now that you don't have the back pain anymore?
Well, I'm going to get my life back together. I've got a new job, and they've saved it for me. My boss is wonderful, and I'm going to go back to work tomorrow, actually, if you can believe that.
Yeah.
And I'm going to start riding my bicycle again and getting healthy again.
Well, your surgery went very well. I don't know if you've watched it yet, but we were able to get in with a tiny 7mm quarter-inch incision and fix both painful discs, and they were both very painful for you. And the pain was coming from a small tear that's located in the back of your disc where your herniation came out of. And that tear was just so inflamed, and we were able to clean out the herniation that was stuck in your tear and use the laser to debride it. And that's what the Deuk laser disc repair is. It's a debridement of the annular tear to eliminate back pain and leg symptoms. So we also have a cyst. We didn't treat your cyst. And do you think the cyst is causing any problems for you?
At this point, no. I don't think so, because all of my symptoms are gone. This morning when I woke up, I was a little nervous about getting out of bed. But that subsided quickly when I stood up and could stand up completely erect with no pain or bindage feeling in my back.
Yes, when I walked in and saw him this morning for the first time, the first thing your mother said was, "Look how straight he's standing." So they must have watched you suffer for a long time.
Oh yeah. Yeah, my mom's a great lady. I'm blessed to have her in my life. And then that's my stepfather, Jerry. He's a wonderful man. He and I are pilots. We fly together. We do a lot of things. And he's seen me go downhill. He knew something was wrong, you know.
How did you find out about us?
I've been seeing a chiropractor in Sacramento for 35 years. And 2 months ago, I started to really feel bad. And I would go to him. And after about a month of going to him, and going to my doctor for some pain management for these symptoms, I finally figured out that something else was wrong with me. And so I asked the chiropractor, what can we do, because what you're doing is not helping me. My doctor put me on pain meds, and they took some of the sharp pain away, but nothing was helping. And so, being kind of a mechanical engineer, I decided to look into how my back was put together. And I requested an MRI from my doctor and from my chiropractor. And so that took 3 weeks to schedule. That's a long story. And I finally got an MRI, and I looked at it myself and realized that I had a cyst of some sort and that I had some problems with my lower discs. And that's when my chiropractor told me about you. He said, get on the internet and do some research and then call these people. So I called your store. They gave me some information. I FedExed my package to you guys, and a week later you called me. And about a week or two later, I got here.
Wonderful.
So, yeah.
And here you are, pain-free for the first time in many years.
Many years.
Congratulations.
Yeah. Thank you.
Is there anything you want to say to your fans out there?
There is. This is a miracle. In Sacramento, everybody that I know said, why are you going? Why are you going to Florida? Why don't you find somebody in Sacramento? And I said, well, because I was referred to Dr. Deuk, and I've done a bunch of research on him, and I just have a great feeling about him. Not only that, he personally called me on the telephone because I told his people that I had some questions, and that's what sealed the deal. And so it took a while to get here, but it was worth everything. And I would recommend anybody send your MRI to this guy, and if he can help you, he will. Okay? Thank you, Doc.
You're welcome, sir. It's my pleasure.
Yeah, absolutely.
All right, go enjoy the rest of your
All right,
life.
thank you.